Our guest speaker today is Carolyn Rich Curtis, Ph.D. She is a licensed marriage and family therapist and the founder of Relationship Skills Center. The Relationship Skills Center has been recognized as one of the leading organizations in the nation in building healthy relationships, and it was awarded 2 Healthy Marriage federal grants. In recognition of her innovations, 3 monographs were written about the Skills Center, and Carolyn spoke at the White House. In her clinical practice, she specialized in working with couples in alcohol abuse and trauma. She was an adjunct faculty member in the psychology department of California State University, Sacramento, and the American River College, teaching child development, human sexuality, stress management, applied psychological principles, and introduction to psychology. Carolyn is the trainer of facilitators in a variety of programs, and she is a certified clinical trauma professional and certified imago therapist. We are thrilled to have her share her passion and expertise with us today. Carolyn, welcome.
Thank you so much, Dixie, and it is an honor and a privilege to be here. And I'm delighted to talk to you about trauma-informed care and beyond today, which I think is one of those cutting-edge topics that we need to be paying attention to, and something I've had passion about for a number of years. If we can move to the next slide. At the Relationship Skills Center, we worked with low-income couples with children, low-income single parents, and youth. And we used Love Notes, Mastering the Mysteries of Love, and Money Habitudes. And these are all programs. Love Notes and Money Habitudes are available through the Dibble Institute, and we have, over the 10 years, have found that we've really loved these programs and have been delighted with their effectiveness.
Well, Carolyn, before we get too far into this today, I'm wondering if you can describe to us the difference between trauma-informed and trauma-informed care.
Yes. Let's, if we move to the next slide, let me just talk about for a moment what trauma-informed means. It means recognizing that people often have many different types of trauma in their lives. People who have been traumatized need to be supported and understood by those people around them, and often trauma survivors can be re-traumatized by well-meaning caregivers and community service providers. So when we talk about trauma-informed, it means the entire organization has this kind of understanding about the effects of trauma. Trauma-informed care is an organizational structure and treatment framework that involves understanding, recognizing, and responding to the effects of all types of trauma. Trauma-informed care also emphasizes physical, psychological, and emotional safety for both consumers and providers, and helps survivors rebuild a sense of control and empowerment. So any organization can become trauma-informed, because that means we have that kind of sensitivity to our participants who've been traumatized. And trauma-informed care means that we change our organization and really focus on healing the trauma. So any organization can add trauma-informed to their organization, and in order to do trauma-informed care, you need to make more changes. So as I go through this presentation, you can start thinking about what kinds of things can we change in our organization to support people who've been traumatized. And on the screen in front of you are the 6 key items for what is trauma-informed care. And we're going to go over each one of these individually. So if you don't get them all written down right now, we'll come back to them and you'll notice that, oh yeah, here's number 1. So on to the next slide. what first we need to recognize how prevalent trauma is. And one of the first true understandings of how prevalent trauma is was done by a fellow by the name of Folletti in San Diego with 17,000 Kaiser patients in San Diego. Now, please be aware, this is not Oakland. This is not some other communities that are recognized for high levels of violence. This is San Diego, and these people had health insurance. And this study was done in the 1970s. And what he found in the study of, and how he found this was he was doing work with obesity, and he would get his patients to lose 100 pounds, and then many of them put the weight right back on. He had one person who had lost 100 pounds in a week. She put them all back on. And he went to understand, how did this happen? And when he talked to her, he found out that some gentleman had asked her to coffee. And that terrorized her so much that she ate 24 hours a day, 7 days a week, till she put the 100 pounds back on. And that, when he went to find out what was going on, he found out that she had been molested. And he then found out that all of the people who had put the weight back on had been molested. So he then did a study of adverse childhood experiences and found 10 items that he tested for, and found that almost 2/3 of participants reported at least one adverse childhood experience, and more than 1 in 5 reported 3 or more adverse childhood experiences. And today in our community, this is referred to ACEs. And the next slide, which we'll look at very shortly, is the list of the 10 of them. I don't let you look at this long because I don't want you to start figuring out which ones you've had. So let's take a look, all right, really quickly to the next slide, because I don't want you to figure out which ones you've had. All you need to do is go to Google and put in adverse childhood experience, and you can look at these 10. And but I found if I do this, people start figuring out which ones they've had, and then they start thinking about them, and then they're no longer available for the rest of the sessions. Now, here are some other numbers. And we recently found that someone else had done some study about ACEs in youth in the juvenile justice system. They found 90% of youth in this particular juvenile justice system had one adverse childhood experience. 84% had more than one, and 55% had 55% of them had 6 or more adverse childhood experiences. Now, why is this important to know? Why is it important for our population to know? Is that they need to know that there are other people out there who've had what they've had, that they are not alone in this. Recently, I've been very, very, very ill, and I was in the hospital, and I was sharing that being in the hospital was traumatizing for me because I had been basically abandoned in a hospital for 3 days with a brain concussion when I was 4 years old. When I told this story to the nurses, what they said to me was, everybody has one. So as they're working on the hospital ward with cancer patients, their experience is that everybody has trauma. And most of my nurses were from the Philippines. So as we normalize this, then it gets to be more okay to share this. And look at this. 50% of our Head Start children have 3 or more ACEs before they even start Head Start. Next slide, please. Now, this is why this is important, is adverse childhood experiences disrupts the neurodevelopment of people. And as a result, they become socially, emotionally, and cognitively impaired. So they just have a lot of problems. Those kinds of problems about social, emotional, and cognitive development, people then adopt health risk behaviors to deal with this trauma. This includes alcohol and drug abuse, running away from home, multiple sex partners. You know, most of the health problems we face today start right here with our health risk behavior, smoking, and then that leads to disease, disability, and social problems, which are more people involved in our social justice system, and early death. Okay, on to the next slide. Now, this is number 2 and 3 of what it means to be a trauma-informed organization. And that is that the organization recognizes how widespread this trauma is. And in fact, it's recommended that you screen your participants for their exposure for trauma so that you have an idea in your own organization how much of this is a factor with the people you're working with. And also do a screening for the symptoms of trauma. So as you do this, you have your organization, your program, or system recognize how widespread this is, and that also includes looking at your own staff and yourself. Number 3 is recognizing the signs and symptoms of trauma in staff, clients, and others. Next slide. Trauma changes our brain. And they're beginning to look at studies with the children and grandchildren of Holocaust survivors to see if there's been a change in brains from one generation to the next. So this is going to take some time for everyone to heal. So on to the next slide. The primary thing that happens when we're traumatized is that the neocortex becomes overwhelmed and shuts down, and memory is encoded with sensory memory. And we're going to talk about what this means in the next few slides. The neocortex, by the way, is the frontal lobes of your brain, right behind your forehead. Okay, next slide. Now, this is the way it works. When you have a day-to-day activity or a day-to-day kind of life where there's nothing traumatizing going on, you develop a memory that has a logical order to it. It's chronological and coded with language. When you've been traumatized, you have a different memory system. You have an implicit memory system, and it is encoded in your brain in emotions, in smells, in sensations, in sounds, in images. I'm sure all of you have watched enough movies with soldiers who have come back from the war and are traumatized by backfire in a car that it reminds them of a gun going off. Now, that is a memory that has been done in the sound system of the brain. Probably for some of you, you have some smells, and for me, eucalyptus reminds me of my childhood because we had a grove of eucalyptus trees behind our house. So these different memories are connected to different parts of our brain. They're not encoded in a way that is easy for us to bring up and memorize. Remember, they are encoded in sections because our frontal cortex, our thinking part of our brain, is not available. On to the next slide. Now, I like this way of thinking about our brain because it allows it to make sense without it becoming just overwhelming. So let's think about the cook. The cook is how our sensations are examined in disassociated segments. Now, what does that mean is that when we see something, it goes to the visual part of our brain. When we hear something, it goes to the hearing part of our brain. And they're all in these different segments. And the cook basically is deciding which ones to pay attention to. But they're all just in these disassociated segments. And that is what we just talked about, is how memory is encoded in these segments in our implicit memory. Now we have a smoke detector. This is up the brain stem, so up the back of your neck and in the center of your brain. It is the most primitive part of our brain, and it acts like a smoke detector. This is the part of our brain that looks at danger. You know, when you're in your house, when that smoke detector goes off, first of all, remember that a smoke detector can only detect smoke. It can't detect whether it is your toaster that is burning the toast or whether your house is on fire. It just responds. Whether the stimulus is relevant or not, it just goes off. And when that smoke detector goes off, it is the only thing you can think about. Now, I'd like you to imagine if you're sitting here listening to this webinar, and all of a sudden the smoke detector goes off, and you know how loud and how irritating that is, you probably are going to stop paying attention to this webinar and find out why that smoke detector is going off. That is what it's like to be the people we work with, is their smoke detector is highly, highly sensitive. They see danger in so many different ways. In fact, people who've been traumatized are incredibly good at detecting whether somebody is angry or not. Just small, little changes. They may be aware that you're angry even before you're angry. That is how sensitive their smoke detector is. And when that smoke detector is going on, nothing else is going on. They're not going to be learning. They're going to be busy protecting themselves. Then we have the Watchtower. Now, this is the cerebral cortex. This is the higher level of functioning. This is the part of our brain that thinks, and it analyzes, and it has objectivity. It is very slow. The smoke detector is very fast, but the Watchtower is very, very slow. We'll just stay with the smoke detector analogy, that the smoke detector is busy going, oh my goodness, what is going on? Stop this. We got to find out what's happening here. The Watchtower would go, let's figure out what's going on here. And it's very, very slow, and it's very analytical. Another important thing to know is that when you're traumatized, the Broca area of your brain, which is the speech area of your brain, is shut down. So a lot of times you don't have language to express what's going on or what you're feeling or what you're thinking. You're just in the moment. The other thing that happens is that your emotional brain, the right hemisphere, is activated, and you shut down the left hemisphere, which is your logical part. So you can see that your brain is just working entirely differently when you've been traumatized. Then the last, and this is a phrase that shows up in trauma work over and over again, is that nerves that fire together wire together. So if two things happen together, you have a traumatic event and you have a smell. Those now are wired together so that when you have that smell, that memory will come up. So nerves that fire together wire together. Okay, on to the next part. Now, when we have a perceived threat, these are the kinds of changes that happen to us. Our heart rate goes up, our breathing rate goes up, the amount of breath we take goes down. You can imagine that you're sort of panting. Your centralized circulation goes up, muscle tension goes up, your energy level goes up. By the way, your digestive system goes down. If you think about this, if you are being chased by a saber-toothed tiger, you are not going to notice you're hungry. All you're going to think about is that tiger chasing you and getting out of its way. So all of these things, parts of our body and our brain, are activated, and at that point we have a choice of fleeing or fighting or freezing. And the most damaging is freezing. Trauma occurs when people feel like they can't get away. They are trapped. And that is why child abuse is so harmful, is because this is our caretaker and we cannot get away. And that is one of the key ingredients of trauma, is feeling that you have no power at all. Okay, on to the next slide. Now, these are the symptoms and behaviors that go with traumatized behavior, or traumatized events. So first of all, we have an event. This may be, for me, I'll just use the example of me being in the hospital. I'm in the hospital. And what happens is I start having memories of being abandoned in that hospital when I was 4 years old. And let me tell you, I want to do whatever I can to avoid being in a hospital, thinking about hospitals. I don't want to be there at all. And in fact, what I really want to do is disassociate, which means take myself in my brain and go someplace else. When I was in school, I grew up in a very abusive, alcoholic family, and I learned how to disassociate, which was not be there. And I would go to school, and I would be accused of daydreaming. But I wasn't daydreaming. I was just associating. You can't learn, after you listen to your parents yell and scream at each other and argue at each other and beat my brother, it's really hard to go to school and concentrate. So that is all part of avoidance. Now we end up with the next step is negative cognitions and mood, which is I begin thinking that there's something wrong with me, I'm not good enough, I'm a bad little girl. All of those kinds of things start coming up. And by the way, that did come up while I was in the hospital, is those negative cognitions, is I'm being bad, I have to be good. And by the way, I was incredibly in trouble in the hospital because I would get out of bed and set off the alarm, which would bring everybody running in, and there I would be once again recreating my childhood. So the negative cognitions would come in about I'm being a bad girl. My heart rate would go up, my blood pressure would go up, and I would have that arousal and reactivity. Amazing how this could all just come up again. On to the next slide. Now, what happens? What are the things that we notice happens when people have a post-traumatic response? And a lot of times it ranges. So this is a range of things that can happen. Now, I will tell you at different times in my life, I have managed to say, while I'm going through a really difficult time, saying to myself, what is it I'm supposed to learn from this experience? I want you to know I could never figure that out until I was out of the experience. But some people manage to take really difficult times and figure it out how to use that to grow. The most common, by the way, diagnosis in our society is generalized anxiety and depression. Definitely can come with trauma. Then what we have is dissociative disorders, which is that fading out and disassociating, and dissociative identity disorder, which is another name for multiple personality disorder. Now, I also think there are a lot of other diagnoses that we give today to kids that sometimes ADHD, sometimes they're accused of acting out. conduct disorder, and many of those are based on trauma. I'm not going to go into the political ramifications of this, but just to make a point is Bethel Vandercook brought forward a new diagnosis, which was called developmental trauma disorder, and the American Psychological Association, in their wisdom, decided not to put it in the DSM because they didn't believe that children would change because of trauma. So if any of you have any connections with the American Psychological Disorder, please voice your complaint. Now, why is this important for us to know? It's important for us to know because people who've been traumatized need to know that my reactions are normal and it's not my fault. There is good reason why I behave the way I behave. And by training your staff in this information, it will allow them to have a greater empathetic response when they see somebody who is highly irritable. You know, someone who's one of your staff people where someone walks in unexpectedly and is irritated and upset, that they will know that it's not about them, it's about what has happened to them that has brought this forward. So we can move forward with this. Okay, on to the next slide. Now, what I want you to know here in this section is that all of our organizations can do something about healing people who've been traumatized. And there are lots of ways that we can work using trauma-informed, evidence-based, and emerging best practices to move forward to healing. Secondly, no one method works for all people. So what may work with one person will not work with another. I heard a story with someone who was teaching someone with to shut their eyes and take a deep breath. Well, that just brought up an emotional response for that client because that was what their parents did before they hit them, is ask them to shut their eyes. So you have to know and get to know the people that you're working with. So on to the next slide. Now, I think it's pretty wonderful is that there is a meta-analysis of 54 different trauma experts, and they found these 6 paths for healing. And many of these are in our curriculum that you probably are currently using. So emotional regulation strategies, learning how to calm yourself down, narration of traumatic memory. And one of the things I want to underline here is that we have found that without a lot of preparation, doing a narration of your traumatic memory will actually re-traumatize you. So please make sure you're a professional before you go there. Cognitive restructuring, helping people to understand that they're not bad, that they're good people. Anxiety and stress management. Interpersonal skills, which of course is in Love Notes. Meditation and mindfulness interventions have all been demonstrated to be a valuable keys and tools for healing people. On to the next slide. This is Eric Gentry's model for healing trauma. And the key and the base for healing trauma is building and maintaining a relationship between your organization and the participants so that they know that they are cared for in this organization. The second step is developing relaxation and self-regulation skills. And lastly, doing a narrative. And as I said, the narrative is left to be done by people with clinical background. So, on to the next slide. So the first question that we ask in doing this work is, helping people distinguish between I am safe and I feel safe. And many of our participants cannot tell the difference, that they walk around not feeling safe, and therefore they think they are not safe. So that may be one of the first questions you ask in your program is, do you feel safe right now in this room? And that is one of those key items that we need to work with. So, am I safe, or am I feel safe? Because without safety, remember, people cannot learn. And that leads to the next slide, which is Scott Miller's feedback-informed therapy. And I think this is something we can take to all of our organizations, not just in therapy, but regularly getting feedback from our participants on, are they feeling safe? Are they feeling heard? Was there something they wanted to deal with that didn't get dealt with? And his work is shown by taking getting regular feedback from our participants that, excuse me, that getting feedback from our participants highly increases the effectiveness of our program and reduces dropout rates. So when people feel heard and listened to and safe, they want to come back. All right, next. Now, this is really a pretty optimistic place, which is here are a huge number of things that we can do in our program to help them self-soothe and heal from their trauma. The ones that are in bold and are underlined are ones that are best left for clinicians. And they're all very effective. Primarily, we're after getting people to calm themselves. A couple of ones that I like to share stories about is, one of them is the internal vault. And I worked with a client a long time ago who had been severely traumatized, and I asked him to take his thought and put it in a safe and shut the safe. And that wasn't enough. So then we put it in a room that was made out of cement, and he shut the door and barred the door, and that was still not enough. And then we had him drop it to the bottom of the ocean. And he came back the following week and told me how much better he felt, because every time he had an intrusive thought, he had a way to go with it. So that's a really easy system that anybody could do with. Progressive relaxation is an old tool, which is you tense a muscle and then you relax it. Emotional freedom techniques is a tool that you can actually find on YouTube, and it's about tapping on acupuncture points. All of these items that I have listed here have been shown with evidence-based or best practices work. Athletics. So many people have healed by getting involved in sports and music and dancing. One of my favorite stories has to do with the fellow in South Africa, whose name just escapes me right now. And he would be having a gathering about healing and people telling their stories. And when tension got great and he could feel it in the room, he would have everybody leave and go out, and they would do drumming and dancing until those feelings were released. And then they came back in and do more work. So there are lots of things that we can do to help people deal with the trauma that they've had. Next slide. Here are some items that many of us, I didn't know for a long time, some simple ways to bring immediate relief. And one is the peripheral vision. And what this is, and for many of our participants, they need to be able to do something in the moment which doesn't make them a center of attention. And I'm thinking of a job interview. So they're busy looking at someone, looking at their teacher, but they're really checking out their peripheral vision. When we are re-traumatized, when we have these intrusive thoughts, we have a nerve that goes from the top of our head to the bottom of our pelvis. And this nerve starts firing. So when we do this peripheral vision, looking forward, looking at your teacher, but really noticing everything on the side, that calms the vagus nerve that's at the top of your head and will give you some relief. The other one is the pelvic floor relaxation, which is you note your pelvic bones and your bones as you're sitting, the bones you're sitting on, and you imagine them forming a square, and you focus on relaxing and expanding them, and that calms the vagus nerve at the bottom of them. And these are two items that people could do in a classroom, in a job interview, talking to their parents, that would allow them to calm themselves down and soothe themselves. Next one. My favorite, of course, is finding a person who you can trust and who you can love and you feel loves you. And this means getting all the relationship skills that we can possibly teach and that people can self-soothe as that they can move through their trauma. There's nothing like having somebody who loves you hear your life story and loves and accepts you no matter what has happened to you as a child. So if your partner is attuned and your partner is empathetic, this is a healing source for trauma. In good old psychobabble, this partner becomes your new permanent object, what you were missing as a child that you can work through. Okay, next slide. Responds by fully integrating knowledge of trauma into policies, procedures, practices, and settings. So this is about changing your organization. Move to the next slide. So what you're going to be focusing on is these 7 principles. One is providing safety for our participants, that you are trustworthy and transparent so people know what is going on, that you have a sense of that this is a collaboration between your participants and you. This is not you doing something to them, but this is they are mutually engaged in their own healing, that our goal is to empower them and build on their strengths and acknowledge and value their resistance. Your organization needs to be culturally, historically, and gender sensitive so that you understand that not everybody will see or believe or feel the same way you do. And lastly is to recognize that change is a process. Next slide. I always think it's interesting that it's the little things that matter. So regular interactions that express kindness, patience, reassurance, calmness, acceptance, and listening. Those are the kinds of things that create the sense of safety that people can grow in. So take a look at your organization. When you walk in the door, is it a comfortable, calming, clean environment? Are the messages that are up pleasant, inspiring, and hopeful so that your whole organization carries that message. And small words that mean the world of please and thank you. On to the next one. So why is all of this important? First of all, we may unintentionally cause harm. And not only, that this will be something that you have said or done just in a moment and not realize that you have just brought up everything in someone's childhood. And second is you need to recognize your own traumatic experiences. When you work with people who have traumatized, they have a way of bringing up what you have experienced. And so that people in the caring profession many times are re-traumatized from their own experiences or traumatized by listening to everyone else's trauma. Last slide. Now, why is this important? Trauma moves from one generation to another. And as we do this, as we make these changes in our environment, in our community, in our agencies, in our families, we improve the life for ourselves, our children, and our grandchildren. I want to thank you very much.
Thank you, Carolyn, for sharing this really valuable information with all of us. Here is a great example how knowledge is power. And we've been able to identify today the difference between trauma-informed and trauma-informed care, what it is, how to address it, and who should do that. And after this webinar is aired, if people have questions, would they be able to contact you at this email address that's there?
Yes, please do. I'm really interested in supporting people in doing this work, so please have them give me a call.
Okay. I have another question, if you wouldn't mind, and that is, do you think, and you've kind of answered this, but I want to re-ask it, do you think that trauma-informed care strengthens knowledge and skills that are learned in healthy relationship education?
Oh, I'm so glad you brought this up, Dixie. One of the things that I got engaged in this was I think the material and the information we teach is incredibly important. And then I asked myself, how can we make what we do work even better? I'm sitting here thinking about the information we give about picking a healthy partner. And then we need to ask ourselves, now we've been giving them all that logical information, how come they haven't been able to apply it? And this answers that question. For those that haven't been able to apply it, why haven't they? And it is that their anxiety level goes up so much that they're not really able to think clearly. So I think this work will make our other work far more effective.
Okay. So you're saying that by an agency or us as individuals being aware of what trauma-informed care is, implementing it into our agencies, that it will impact the healthy relationship education that we'll be providing in those agencies.
Yes. One of the things I thought was interesting in my readings is that one of the signs that someone is having intrusive thoughts is their legs begin to shake. I thought, how many times have I taught a class where I watched somebody's legs begin to shake, and I didn't pause and ask people to take a breath, to calm down for just a moment, so that, or, talk about, change where I was going just a moment about why whatever I'm talking about might be hard to hear, so that people could actually be present, and that I've caught up with their body language that is telling me something is going on here that I need to attend to.
So when we are addressing topics in healthy relationship education, like what is healthy and safe and domestic violence or dating violence, and even communication skills. Being aware of trauma-informed care may help us to better deliver that.
Oh, yes. And also that when they notice that their leg is shaking, that they would have a way of self-soothing so that they could actually, calm down that smoke alarm so that they could get their frontal cortex, their watchtower to start to work.
Okay.
So that they could self-soothe, because that's what they need to be able to do in order to learn the material that we're teaching them. So they go hand in hand. That's how I see it.
Yes.
They go hand in hand.
Yes. Very powerful, very powerful. Well, I'm sure that, again, when this presentation is broadcast, that there's going to be plethora of questions. We look forward to collecting those and also passing those along for further discussion. Who knows, maybe there'll be another broadcast about this in the future and take it to another level. Again, I want to thank you today, Carolyn, for taking your time, sharing your passion and your expertise with us. We greatly appreciate it.
Well, it's been my honor and privilege. Thank you so much, Dixie.
You're welcome. Thank you.